So it's a real pleasure to be with you, albeit sitting here in Paris. It's already in the afternoon, but virtual techniques make the world so small, though, so we can discuss together an important issue. And thanks to the Nestle Health Science to bring up this symposium, allowing us to discuss nutritional therapy, which is an extremely important point to take care of our patients with IBD. My little slide of conflicts of interests, no conflict with this presentation. To answer the question, is there still a place for nutritional therapy, albeit many biological therapies? I'd like to start to review with you. I think most of you are familiar with the evolution of IBD. With time, we have patients who start their disease with an inflammatory burden that will bring up clinical symptoms, and this will lead to the diagnosis of IBD. The aim of therapy is to block this inflammatory reaction, but many patients do have repeated flares, as indicated here in purple in this figure. And with time, there's a risk to accumulate complications leading to loss of function of the intestinal tract, leading to disability. And this is highlighted here with the appearance of strictures, fistula, leading to surgery and loss of bowel function with time. This is to be avoided. And there is, we all know now, a real window of opportunity to protect our patients from these complications with time by treating them very early and avoiding the inflammatory process to lead to these strictures and fistula. And the optimal treatment would be an evolution like this, having one flare leading to the disease diagnosis and then completely control the disease without having these complications with time. We know that since the late 90s, early 2000s, the introduction of TNF medication, that there's a real gain for our patients and marked reduced complication, disease evolution for many, if not most, of our patients. How to measure this effect of biologic therapy? Here, infliximab, intravenous anti-TNF medication. The easiest way and best way to illustrate the efficacy is to look on the evolution with time, as highlighted here, over 5, 10, up to 20 years, with regard to complications. This is an adult cohort of the Netherlands on about 1,100 patients, separated in 3 different cohorts based on the diagnosis between 91, 98, 99, 2005, the early introduction of anti-TNF, end of 99, and 2006, 2011, where anti-TNF medication is integral part of the treatment algorithm. And as highlighted here in this study published 3 or 4 years back now, you see a marked reduction between the different populations treated without anti-TNF or routine anti-TNF for complicated disease, in number of hospitalizations, and even more important, in number of surgery requirement, meaning resection surgery. So there is a clear established role of this treatment algorithm to protect the patients from severe evolution and the complications, as we just discussed. We did translate this to the pediatric field. This is the update of the European ESPGHAN and ECCO guidelines to treat Crohn's disease, pediatric Crohn's disease, published in 2020, the revised version. And you clearly see at diagnosis, children who do have an active disease with factors that predict risk of complicated evolution, the early introduction of anti-TNF medication is really recommended. The strategy is not validated by randomized clinical trials, and there's an ongoing trial in Europe called Reduce Risk that will, hopefully or not, we will see the results, validate this strategy. The trial is almost finished. But there is a clear place also for other induction therapies, and here we come to nutritional therapy in patients who probably are not so severe, but we have to discuss this, and there are alternatives to anti-TNF medication. What is the problem? Why do we not put all our patients at disease onset on anti-TNF medication? One, there is primary non-response, not very frequent in the pediatric field, but some patients do not respond. Markedly more important, there's secondary loss of response. most often due to immunogenicity, and there is the risk of side effects and total drug toxicity. So if we look into details, we have several pediatric reports that looked on duration with anti-TNF medication is highlighted here in this graph, and the number of patients who lose response. And overall, these studies, we see about 1/3 of patients who lose response within 2 to 3 years of therapy, and the number is increasing with time. So there is a need to improve therapy for patients who did respond to anti-TNF medication, but who lose response with time. And the second and perhaps more important problem can be the occurrence of side effects. This is a huge French study published in JAMA in 2017 based on almost 190,000 IBD patients, majority adult, but all pediatric patients in France were included. It's based on the analysis of the National Health Insurance Claim Database, looking on occurrence of lymphoma. And you see with time, this is indicated here in months, patients who are unexposed to biologics, who are exposed to combo therapy in red, anti-TNF alone or thiopurine they do have a different risk profile to develop lymphoma. And the highest risk in this study is clearly in those patients who are exposed to combo therapy. So in our guidelines, in ESPGHAN CD guidelines, we clearly define what is the objective to treat our patients is they have no more symptoms. They do heal the inflammatory lesions, what we call now mucosal healing and clinical remission. We have a particular look on growth, optimize growth and bone density, and to improve quality of life. And as just highlighted and discussed, minimize drug toxicity. So is there a place for alternative treatment strategies from the very beginning for our patients? The answer is very clear. It is yes. These are the statements of our guidelines in the first version and confirmed in the second updated version. We state that exclusive enteral nutrition is recommended as first-line therapy to induce remission in children with active luminal disease. On the other side, we clearly state that partial enteral nutrition, meaning enteral nutrition with normal food intake, as the habits are in this family, should not be used as induction of remission therapy. And the new guidelines repeat, exclusive enteral remission is first-line therapy for our patients with active luminal disease. Why do we recommend this? We know, this is a patient that we published many years back, that induction therapy with the enteral nutrition on an exclusive basis can heal deep mucosal lesions. This is a colonic lesion, and you see after 2 months of enteral nutrition and adding on time azathioprine medication, but this is not the azathioprine effect. We clearly see this very nice healing, mucosal healing in the transverse colon. Several studies, most are only case series. This is a randomized, a very small but randomized trial, randomizing new patients at diagnosis to steroid medication on one side or exclusive enteral nutrition based on MODULEN IBD. And you see that patients do respond with remission in a similar manner, but there's a marked difference. If you look on the outcome on follow-up endoscopy, you see a better response of achieving mucosal healing in those patients who were on exclusive enteral nutrition MODULEN IBD compared to steroids. These are small numbers of patients. It's the absolute number of patients is not very high, but it's a very important result in this randomized trial and highlighting other trials in the past that were open. This is a study of the Italian colleagues who looked on mucosal healing. There was a clear advantage for those patients who were on enteral nutrition, as highlighted here in white. And they even looked on mucosal healing on the histological score. And you see also in the ileum as well as in the colon, there's a clear reduction in the inflammatory load in patients who treated with nutritional therapy compared to those on steroids. Older meta-analyses, and the recent one did confirm it on the same way. There is equal efficacy to induce remission in patients with Crohn's disease, luminal Crohn's disease, if you use steroids or enteral nutritions. So the question is, why do our patients in Europe, as you are aware, we use more often nutritional therapy as induction therapy compared to colleagues in North America? I don't know if you use in your clinical routine practice. Sometimes centers do, but others do not use nutritional therapy. The question is, why is it successful and why do our patients accept it? This nutritional therapy, that is quite complicated, and we'll discuss it after the talk of Ari Levine, who will show us that the exclusivity principle is a little bit different today, since there are alternative treatment strategies. Our patients do accept it very easily because they do have very often, as shown in one of my patients, a boy with Crohn's disease, marked growth retardation. This patient diagnosis was treated with steroids in another center. You see there is weight gain and relief of symptoms, but it aggravated growth retardation. And when the patient came to see me, we put him on a flare on enteral nutrition, and you see a very nice catch-up growth. So the growth issue matters, but also the patients, when they are on nutritional therapy, they respond very quickly. Within a couple of days, they do have relief of symptoms. And as highlighted in this British study many years back, there's a very fast drop of inflammatory parameters that highlight or echo this clinical response. It's really within 3 to 5 days, the patients feel better. So they are motivated to adhere to this treatment. As already said, if patients are on partial enteral nutrition, meaning they do use the product, plus they remain with their usual diet, the response is very borderline, if not at all. However, if they are on complete total enteral nutrition or exclusive enteral nutrition, there's a significant effect on controlling the symptoms of the patients. British study published in 2006 in Gut. What the patients do not like is that they use a nasogastric tube feeding, which was done in the very past. And in our center for many years, and now many centers, they stopped using nasogastric tube feeding, but go over to oral administration. And oral administration became significantly more acceptable for the patients due to the introduction of polymeric diet and not elemental diet, which is quite difficult to take over a prolonged period. Small study that we published a couple of years back showed that there is no real difference in efficacy, drop in the PCDI score in patients on oral in white taken enteral nutrition or by nasogastric tube. Here in the shadowed barrows, you see it's a little bit faster if it's by tube, but in the end, after 2 months, 8 weeks of exclusive enteral nutrition, the result is the same. So there's no difference. And that's the reason why we do not use nasogastric tube feeding for these patients anymore in our center. Which type of diet? Several studies, most often small studies, but in the end, the conclusion is there is no real difference if you compare elemental diets versus polymeric diets, but the polymeric diet, the palatability is better, so easier accepted. And once more, put together on this little slide, exclusive enteral nutrition means no food at all. It's taken orally, preferred, but it can be given by nasogastric tube. You can use polymeric or elemental diet. The patient's preference often is on polymeric diet. How long to use? I showed you the study, it's over 2 months. We use it usually 6 to 8 weeks. And it's independent if the patient has colonic or small bowel involvement. It is luminal disease that can or do respond to enteral nutrition. How do we think that we can obtain this effect on mucosal healing, on calming inflammation by using just a liquid diet? We believe that there is a positive impact, that there is an impact of the environment. This cartoon shows the intestinal mucosa with the immune system that is well organized. And there is a chronic stimulation that leads to up-regulation of inflammatory pathways that will result in the disease. So the aim is to reduce this inflammatory load. And we now have arguments that there's not only a change in the diet, which is logical if you introduce only a milk-based liquid diet, but there is also a change in the so-called dysbiosis that we see in our patients, meaning the dysregulation of the luminal bacteria is shifted towards a more advantageous situation under the nutritional therapy, an effect that we cannot obtain with with drug therapy. which is not affecting directly the bacteria. Just to highlight what I tried to tell you in a study that we published 2 years back, before therapy, the dysbiosis explained here the bacterial composition in the intestinal tract. And if you compare patients that were randomized to enteral nutrition by MODULEN IBD versus steroids, you see after 2 months in the analysis that there is a clear shift in those patients who received the nutritional therapy compared to those patients who have a steroid medication in the bacterial load. Which is the difference in these bacterial species? We saw in the enteral nutrition, it's highlighted here, pre and after 2 months of therapy with nutrition and steroids. There is a marked difference between the groups with regard to firmicutes, actinobacteria, and bacteroidetes. But the problem is there is an inter-individual diversity, and you require, I think, a large number of patients to see really significant results within the groups. So these are studies that are ongoing. I think Ari will tell us a little bit also on this, on his findings. A look into the future, 2021, we do have new data. And I want to share this study, the first results of this study with you. We just finished the analyses early this summer. The study is a prospective randomized clinical trial performed by the French pediatric GTED, which is a group of IBD experts, multi-center over France, and it's called the CD-HOPE study. The CD-HOPE study is new patients with Crohn's disease that receive an induction therapy based on exclusive enteral nutrition, as discussed, orally taken or by nasogastric tube feeding. And they receive therapy for a total of 6 weeks, ±2, to have some space. And those patients who come into remission, so those patients who do respond to nutritional therapy, they are allowed to be randomized to 2 arms and to look over 12 months of therapy, what is the remission rate. The 2 arms are characterized, one by exclusive enteral nutrition as the induction therapy, but every 6 weeks for 2 weeks, as highlighted here. 6-week normal diet, 2-week exclusive enteral nutrition, no food, just MODULEN IBD, another 6-week normal diet, 2 weeks, etc., until the end of 12 months. Versus those patients who have everyday normal diet, they return to normal diet, but they keep 25% of their caloric intake as a MODULEN IBD. And after 12 months, we compared remission rate and the relapse rate in these patients. And the result that is now ready to be submitted for publication, but that I share already with you during this meeting, is that the remission rate is significantly higher in patients who have the cyclic exclusive enteral nutrition compared to those who receive just the supplement and return to normal food. This is after 12 months of therapy. So this is the first study that tells us, indeed, nutritional therapy is not only an attractive candidate and an attractive way to treat our patients as induction therapy, but also as maintenance therapy over at least 1 year. And I have to share with you, or I can share with you, that we have patients that are for more than 3 years on nutritional therapy in this way without ever receiving any drug medication, and they remain in remission. So I'd like to summarize these points I want to share with you, and I showed to you that yes, nutritional therapy in form of exclusive enteral nutrition is highly effective in inducing remission in our patients with luminal Crohn's disease. It is not effective at all for perianal lesions. As logical, the safety profile is excellent, no side effects, but the acceptance is a problem. Our patients do accept easily because it acts fast. It helps to obtain catch-up growth, and all the cosmetic aspects with Cushing, acne, etc., are inexistent with nutritional therapy. As highlighted, oral acceptance rates are highly better than by tube feeding, and we can see this as a top-down approach by looking on the pathophysiology, because it can act on the dysbiosis, which is on top of the inflammatory cascade. And as just shared, there is a potential to use nutritional therapy as long-time medication for our patients with Crohn's disease. Thank you for your attendance.